Hello and welcome to today's class, the class on myths and truths about occlusal adjustment in bruxism for patients with bruxism. If you only perform the occlusal adjustment, this patient will resolve their bruxism. This is a myth that, in fact, we need to understand where occlusal adjustment fits in for patients with bruxism. What you're doing here today, this whole week that I've been doing live sessions, Monday, Tuesday, Wednesday, today is Thursday, and tomorrow there's another live, you are being prepared for the Advanced Dentistry Week, which is an exclusive event for dentists where I teach you, dentists, how you can become a reference in your region, increasing your revenue with great integrity through differential diagnosis, treatment, and control of bruxism, even if today you don't charge for consultations or work with health insurance plans. This is a 100% online free event, and you need to sign up through the link in my Instagram bio or in the comments on YouTube. Pay attention, enter your best email. You'll go to the link, enter your best email, put your WhatsApp number. Don't use the clinic's number because I'm going to send content. I'm going to send PDFs, images, and materials so you can make your first consultation stand out even more. So for those of you who don't know me, my name is Andrea Mello. I'm a dentist, graduated from the State University of Rio de Janeiro. I have a master's degree in material science from IME, a doctorate in dentistry from UERJ, and I'm a dentist just like you. I work in the chair. I know what it's like to present a treatment plan, a financial plan to a patient. And many times the patient doesn't buy into our idea, and you have to explain what the best treatment is for that patient. What are the biases? What are the problems if the patient chooses not to undergo the treatment? And everything I'm going to teach you here is based on science. So I want to bring you the clinical reality, but also the scientific reality, and to talk about the myths and truths regarding occlusal adjustment and bruxism. So let's get started with today's lesson. It's impossible to talk about occlusal adjustment without remembering that the most important muscles for chewing, are these muscles listed here on your left: the temporalis muscle, the main elevator of the mandible, the lateral pterygoid, masseter, digastric, muscles that are highly recruited during the masticatory cycle. And there is a very important plane, which is the campus plane, the condyle guidance, and all those details we learn in dental school, which are important details for occlusion. I know you might be taking many other courses. I know you might be studying other things, and I know you might be afraid of occlusion because many of us are afraid of occlusion since occlusion is not covered in depth in many dental programs. We leave college thinking that occlusion is dangerous, thinking that occlusion is difficult, and I want to tell you that there's no point in taking a bunch of courses without applying them. There's no point in taking a bunch of courses and memorizing footnotes or taking a course where you don't actually apply the content in your daily clinical practice. So you can't just ignore it. Bruxism in this equation. Why? Because bruxism will amplify any problem your patient might have with their occlusion. For example, lateral movement. Canine guidance, look. Left lateral movement. If your premolar touches during lateral movement, you will very likely develop an abfraction. If you have bruxism, it will happen even faster. So bruxism is an amplifier of all problems. We live with adaptive occlusion. In yesterday's class, when you finish today's class, watch yesterday's class, I explained what physiological occlusion is, what pathological occlusion is, and what would be the ideal occlusion, where centric relation is equal to maximum intercuspation. And that happens in 0.000 nobody from birth. Let's put it that way. Ever since the permanent teeth come in. Why? Because there is an adaptive physiological occlusion, which is free of signs and symptoms. What would be a sign or symptom of an occlusion? A pathological one, for example, would be an occlusal dysfunction, a fracture or gingival recession. That would already be an occlusal dysfunction. And where does this happen? This happens when the occlusion is not balanced. But is this bruxism? No. This causes patients with bruxism to have more dental damage than patients who don't have bruxism. My question is, has the patient changed? Who doesn't have bruxism these days? You sit at any bar, you talk to 5 or 6 people, and 4 will say they clench their teeth, or 4 will say they know someone who does. So at this moment, you need to understand, first and foremost, what occlusal adjustment is. What do I need to know as a dentist about occlusal adjustment? When and why should you adjust the occlusion? I'm going to give you the rules of occlusal adjustment, what is occlusal adjustment, and what is not occlusal adjustment. I'll explain this in this slide. In the next one, I'll tell you what bruxism is and what it isn't. And then we'll continue with the line of reasoning for the lesson. So pay attention. Occlusal adjustment means bilateral contacts with the same intensity, distributed in a balanced way, where I have a situation in which the posterior teeth protect the anterior teeth and the anterior teeth protect the posterior teeth. Write that down. And now I'm going to tell you the importance of the canine in all of this. The canine is an extremely important tooth for providing canine guidance. Where do we have canine guidance? Whenever I perform lateral movements. What is an occlusal interference? It's when during a lateral movement, I have a contact that is not just the canine touching. I call this an occlusal interference, that is during lateral movement. This occlusal interference can occur on the working side, meaning canine to canine. This here is the working side. And this here is the balancing side, okay? So balancing side where nothing touches. Canine to canine, working side. Then I come over here to the other side. Now this is the working side. Right side, my right. And this is the balancing side. Nothing touches, only this canine touches. Got it? I can have an interference on the working side, which would be this side here if something touches from the premolar back. Or I can have an interference on the balancing side. I'm moving here, canine to canine, and something is touching here. Interference on the balancing side. So I can have interference on the working side, I can have interference on the balancing side. And what about prematurity? Prematurity is what prevents the centric closure of the mandible. That is, when closing, not in lateral movement, okay? I have a premature contact which touches before the others. That's prematurity. Occlusal interference on the balancing side. Did you write that down? All right. What does this have to do with bruxism? Nothing. Do you know why it has nothing to do with bruxism? Because this is pure occlusion. Now I'm going to add a problem to the equation. Bruxism. What happens with the patient? Has bruxism and creates an interference on the balancing side, for example. What is the balancing side? It's when the patient is sleeping. On the left side here, my left, the patient fell asleep, okay? Look at me. The patient fell asleep here on my left side. Then he rests on this canine here and grinds on this side. He moves over here. So this side here is the working side, is the side where he grinds. And this side here is the side he supports, okay? Got it? Got it. Let's suppose he has an interference on the balancing side in this case, which is supported here, and he has bruxism. In other words, he spends the whole night doing this here. What's going to happen? What happens is that for patients who have occlusal interferences on the balancing side, the TMJ feels it much more. If you're thinking, wow, Andrea, this is getting difficult, stick with me because I'm going to wrap up this equation and you'll understand. It's not difficult. It's just unfamiliar. You who are a dentist of any specialty, endo, prosthetics, ortho, you need to have this knowledge. The patient has bruxism, slept on this side, ground their teeth on the other side. The interference on the balancing side is much more harmful to the TMJ. But this guy doesn't have TMD. He's never had pain. He just has bruxism. And do you know what happened then? It amplified the problem, which was the interference on the balancing side, something he had never felt before. So what happened? He started making this repetitive movement, which is bruxism, this repetitive movement countless times over the years, the last 4 or 5 years, post-COVID. He started doing this movement. No one noticed because he still has the canine tip. And interference. What started to happen? He started to feel pain. Wow, so bruxism can cause pain. It can, but it's not the bruxism that causes the pain. It's the amplification of the problem he already had, which was an occlusal interference. Did you understand the difference? Here's the thing. You need to know in order to explain to the patient what is the cause and what is the effect. And we're used to thinking only about the consequence of bruxism, which is tooth wear. But there are countless other consequences of bruxism that will interfere with your work. For example, a tooth that has had a root canal can fracture. And then what? A tooth that has had a root canal will fracture. You just finish the root canal and the tooth fractures. What do you do then? The patient starts to feel pain in the ear region and interference like the balancing one I just explained. But does everyone have this? No. And does everyone with bruxism have interference? No. I need to look at each case individually. So if you think bruxism doesn't concern you, unfortunately, you're going to be left behind. And soon this is going to overwhelm you and you'll be swallowed up so quickly that you won't even notice. Because since everyone is doing it, everyone is looking for answers. And nowadays there's ChatGPT, there's Google, there's the internet, there's Instagram. Everyone is searching for information. Information has never been so cheap for patients. In the past, a patient had to book an appointment with a top specialist just to understand what I just explained. And I'm sure there are a lot of patients here watching my lecture. So that patient who's watching my lecture could be your patient. So what do you do? All right, let's go. I need to adjust this guy's occlusion. Who's grinding his teeth? Yes, but why do I need to eliminate this interference? But will removing the interference reduce the bruxism? No, it will only reduce the damage. All right, I get it, Andrea. So what do I do to reduce bruxism? That's a different treatment. The treatment for bruxism, which you may or may not want to do. I advise you to do it because this is going to show up more and more in clinics. We have very few professionals prepared for this. So let's go. I've talked, given examples, and provided context. Now I want to bring you the rules for occlusal adjustment. If the contact, the interference, the premature contact, which I've already explained to you what it is in the first third, in that green area there, you can see the occlusal surface of the tooth, and there's green, yellow, and red. If the interference, the contact point, is in the green, that means it's an adjustment by selective grinding, in other words, subtraction. If the interference is in the second third, it's the rule of thirds, okay? Technique of Clifford and Fox. If you have interference in the second third, in the yellow area, you need to assess how much reduction would be required. Because if it's going to be a very large reduction, it's worth considering tooth movement, okay? And the third third always requires tooth movement, no matter what. Now, I have an acronym down there that says KEYS, see? It stands for correction, addition, or subtraction. Correction means orthodontic movement. Addition is when you add dental volume. For example, a patient with bruxism who has lost dental mass or the tip of the canine. You need to restore the canine tip, that's addition. Occlusal adjustment by addition and subtraction is only done when it's in the first third of the cusp, where you see the green area. In that case, you'll use a polishing rubber or a finishing burr, and often that's enough to make the occlusal adjustment, smoothing things out nicely and eliminating that premature contact or occlusal interference. To sum up for you, I explained that there is a method to determine whether you should correct, add, or subtract during occlusal adjustment. But I haven't taught you how to diagnose bruxism, because I explained to you that bruxism is an amplifier of the problem. Looking at a worn canine tip is not diagnosing bruxism. Diagnosing bruxism means understanding what this patient does at night. Today, I can't start an occlusal adjustment or orthodontic treatment, or an endodontic procedure, or a restoration without knowing what the patient will do at night with my work, without knowing if at night he is causing any occlusal interference, because I would be, excuse the word, irresponsible. You know why? Because I would be ignoring something that is completely evident in the office today. Anyone who works with patients knows this. You see more and more worn canines, you see more and more stressed patients, you see everyone on their phones, and this is increasingly raising the prevalence of bruxism to the point that in many scientific studies, we are already using the term bruxism epidemic. I can say bruxism epidemic in quotes as something that is truly happening. And this is a patient, for example, who came to me with a night guard coinciding with mobility, and she was referred to me by an orthodontist to evaluate her bruxism. But do you know what happens? This patient has trauma. The patient is experiencing trauma. But an occlusal trauma amplified by bruxism increases mobility even more. So if you're a periodontist and your patient has a certain level of mobility, if the patient has bruxism, their mobility will double and progress twice as fast. And I know you might not want to leave your comfort zone, which is your zone of familiarity. It's the zone where you're a clinician, the zone where you're a specialist, the zone you have mastered. But the patient has a mouth that's part of a body, which is part of a brain. And this brain is making the patient grind their teeth more and more. So you can't ignore this today and think you'll treat and keep your patients the same way you did 10 years ago, because you won't. Maybe you've been practicing for 30 years, 40 years, and you're thinking, wow, this is too much for me. It's not if you want to keep treating patients. If you want to be a reference and keep treating patients, you'll need to take a stand, because this has hit our offices like an avalanche. So, demystifying occlusal adjustment, I wanted to bring here a quote from Dawson, who is the father of occlusion. A quote from Dawson from 2008, "The fear of occlusal adjustment is also related to the fact that many dentists think any occlusal change can lead to increased occlusal awareness or cause a temporomandibular disorder. In other words, there used to be a myth that occlusal adjustment and TMD were deeply connected. Today, we know that's not the case. Now, what about bruxism in this context? Bruxism, remember, amplifies all problems. Of course, for patients with TMD, we will also remove that interference. Just as for patients with bruxism, we will remove that interference. But it is not the cause of TMD, and it is not the cause of bruxism. And TMD is not bruxism. There are countless patients with bruxism who have no pain, no TMD, and there are many TMD patients who also have bruxism. But the treatment for TMD is one thing, and for bruxism, it's another. Because bruxism is a problem related to specifically nighttime bruxism. And daytime bruxism is also closely related to anxiety. So how can we treat this? I'll explain this during Advanced Dentistry Week. I'll break down the treatment during Advanced Dentistry Week. And I'll explain to you that there are 4 stages of treatment, and you need to stop believing that bruxism treatment is just a mouth guard, for God's sake. I know that's how we were taught, but this patient needs you. It's a huge opportunity. Don't be afraid to step out of your comfort zone, because the time to step out is now. Soon it will be too late, because soon a lot of people will already know, will already be doing it, and then you won't stand out. The time to stand out is when you are different from everyone else. It's the time for you to be different from the ordinary, the common, the average. Today, the average is just giving the patient a mouth guard. So rise above the average. This is the moment to rise above the average. So Dawson says that this trend is the result of brainwashing caused by statements in the literature, clinical warnings, and a deep ignorance of what constitutes harmony in the masticatory system. Reinforced by research that is seriously flawed in defining the type of TMD and in trying to determine the correct relationship between maximum intercuspation and the condition of the TMJ. Dawson is saying that all of this is flawed literature and that using inadequate protocols to correct occlusal disharmonies is also a problem. So I brought here a deep reflection on the relationship that once existed between occlusion and TMD. That relationship has fallen apart. And today I am demystifying for you the idea of a causal effect of bruxism. It's not about occlusion. And let's delve even deeper into the current literature, the effect of occlusal factors on bruxism and orofacial pain. Summarizing this article for you. As a result, malocclusion was found in 28% of the clinical studies patients. While awake bruxism, there are 2 types of bruxism, daytime and nighttime, 2 different times for bruxism. You can have both or just one. Or sometimes, generally, those with awake bruxism have a bit of nighttime bruxism as well. But you can have only nighttime bruxism without the awake type. Awake bruxism was reported in 35% of patients and daytime bruxism in 15%. Let me make a parenthesis here. Do you know why in this study, awake bruxism was reported in 35% of patients and nighttime bruxism in 15%? Because the examination method in this study was self-report, it was based on the patient's own report. Patients who noticed themselves clenching during the day and patients who noticed themselves clenching at night. And let me tell you this, there is an exam to determine whether a patient has nighttime bruxism or not. So this 15% figure for nighttime, it could be much higher because not everyone who has bruxism is aware that they have it. In fact, it's a minority. Do you see how we need to be critical when reading scientific articles? I need to understand how this research was conducted. It's not that it's wrong. It's just that this number is actually even higher. This number is even higher. And I know I'm a master in materials. I have a doctorate in restorative dentistry. I'm in the academic field, but you're a clinician. You don't have time to read 25 articles and question those articles, and still do reviews and still see patients, close the books, pay the accountant, pay the receptionist, pay the dental technician. That's why I want to say to you, congratulations for being here, because you're getting fresh information that I'm bringing to you and you're here paying attention at this time of night. You're already set apart from the rest, so pay attention. Occlusion. It has no direct effect on awake bruxism. Now, there is another study that shows that awake bruxism has a direct effect on periodontal disease. It increases mobility. Of course, it's overload, right? So let's go. Let's keep going. Here's the result. Look, I'll sum it up for you. Awake bruxism, sleep bruxism have no relation to occlusion, to malocclusion. But the more bruxism the patient had, the more pain was found. More pain was found. Of course, what did I explain to you? Amplifier. Amplifier of problems. Now, clinical significance. Malocclusion does not impact the presence or absence of bruxism. However, it increases pain in many patients, both sleep bruxism and awake bruxism. And it also doesn't necessarily impact the diagnosis of TMD. So the clinical significance of this research among dental students in the dental school means, in other words, there is a dental awareness, there is an interesting awareness. It means that the outcome of malocclusion should be reconsidered in restorative dentistry and contemporary oral rehabilitation. So if you are a rehabilitator, this is the moment for you to understand what bruxism is. You understood that malocclusion does not cause bruxism, but bruxism makes any malocclusion worse. So let's go. Bruxism is a movement that can be rhythmic or non-rhythmic. In this case, it's rhythmic, that the patient may perform at night or during the day. Generally, during the day, it is non-rhythmic. However, it's more about clenching, that is non-rhythmic. Rhythmic, eccentric, or phasic, which are synonyms, or non-rhythmic, clenching, centric, right? Clenching, centric, non-rhythmic. Now, if the patient makes a rhythmic movement, that is an eccentric movement, they will have this, loss of canine cusp tips. And if the patient does a tonic movement, the patient clenches, more pressure, centric. What can happen? A longitudinal fracture. But they won't lose the canine cusp tip. Now imagine them doing this on top of your implant without you knowing. What will happen? Mobility. The prosthesis unscrews. The component is loose all the time. There's an emergency, you need to go to the office to fix it. All of this, why? Because the diagnosis wasn't made so of that excessive occlusal force during the night. And you didn't notice it, the patient didn't mention it. You didn't have a 360-degree patient record. For this patient, I'll explain what that means. You followed the path of your specialty because you're there to place an implant or you're there to do a root canal. You didn't ask, and so you let it slip by. So are you going to do a root canal? Make the diagnosis of bruxism. Add that to your patient record, to your diagnosis. Why? Because you need to know whether or not the patient is overloading the work you're doing for them. Whether it's porcelain, right? Whether it's Emax, whether it's feldspathic, whether it's resin, whatever it is, you need to add the diagnosis. So this is another case. Andrea, it's obvious that this patient has bruxism. Of course, everything's already been destroyed. This one is easy to see that they're grinding their teeth. But my question is, are they doing it now or did they do it in the past? How am I going to know if they're doing it now or if it was in the past? I have several pieces of evidence. My Monday class was all about the evidence of bruxism. He has exostosis, evidence of bruxism. He has fractures, evidence of bruxism. He has cracks, evidence of bruxism. He has loss of occlusion of the occlusal surface, evidence of bruxism. But then you think, I got this guy to do a root canal. I get referrals. I'm not going to work on the guy's mouth just because I get a referral. But then I ask you, you're going to do a root canal and you're not going to diagnose bruxism, and the other dentist who referred him to you didn't do it either. Why don't you diagnose bruxism, which I'm going to teach you. During Advanced Dentistry Week, I'll break it all down and give it to him, letting him know you found something that will help him with the restorative part, for example. He's going to do the restoration, and you found out the patient has bruxism, so you're going to ask him, skipping the obvious, right? Do you treat bruxism? No, I don't treat it. I just give them a mouth guard. That's another step if you want to get into the world of treatment. I treat it. Shall we treat this guy? Shall we reduce this occlusal force? Now that's if you want to treat bruxism. If you don't want to treat bruxism but just diagnose it, I'll teach you the exam you need to do. Because you can bring this patient back with the complementary differential exam, with the differential diagnosis, which I'll explain to you still in today's class. There are 4 steps to refer this patient already diagnosed. Now, just a detail, did you see the occlusal there? All with an erosive component. Look here, on this canine number 23, this is a sign of erosion. Classic, classic. And I brought a study to remind you that resin restorations are more susceptible to erosion from saliva. And besides having a resin restoration that's more susceptible to erosion, if you put a splint on this patient, what are you doing? Without doing a differential diagnosis of saliva, creating a little pool of acidic saliva contained by the occlusal splint. Because of bruxism, you put on an occlusal splint, or whoever is doing the restoration puts on an occlusal splint, and that's it. And you're keeping a little pool of acid there, causing even more tooth wear or wear of the restoration in this patient. So be careful. You can't just ignore bruxism and give everyone a splint. Make a diagnosis. What is a diagnosis? To bring light, to bring clarity, to knowledge. So I've given you a lot of knowledge up to this point. Let's go. Bruxism can be diurnal or nocturnal. And now we're going to get into the differential diagnosis. What are the benefits you're going to get? Reference, being a distinguished dentist who goes beyond just teeth, referrals, being recommended by other professionals, patient referrals, a full practice, being a reference so you can charge more, being a reference so you don't have to compete on price because you do what others don't. So be a reference. Now, losses. You'll lose your work being worn down, your patient upset, fractures, problems, loss of revenue. You're already losing money if you have patients like this, if you just do the root canal and send them back. I can already guarantee that you're losing at least 1,000 Rs by going for the cheaper option. With a good diagnosis plus a saliva test, just so you can diagnose using the protocol I'm going to teach you. So be careful not to be losing more than you're earning without even realizing it. And the DTC methodology stands for Differential Diagnosis, Treatment, and Control of Bruxism. There's a step-by-step methodology. That's why you don't need to worry. It's not difficult. It's not unfamiliar. But those who have a methodology can follow it from start to finish. Enough of working a lot and earning little. Enough of working from 8 a.m. to 8 p.m. just to break even. It's time for you to work less and earn more with a better quality of life. So differential diagnosis. 4 steps, Proclair 360, which are the right questions for you to know what your patient does at night and what your patient does during the day. Extraoral and intraoral evaluation, which includes palpation of the head, neck, and masticatory muscles, including facial evaluation. In fact, go ahead and palpate now. Look, he squeezes his masseter with the force of 1 kilogram. 1 kilogram. Does it hurt? Tighten your stoma. Come here. Bite. Do it now. Bite. Tighten your stoma. Tighten your stoma. Does it hurt? If this headache is a familiar headache that you experience, for example, in the morning, I don't know if you feel it, but you have to mention a lot of dentists out there with bruxism because they work a lot. They spend a lot of time in the office, a lot of light, a lot of electronics, poor diet, drank a lot of coffee. You who have coffee at 5 in the afternoon, you lose your temporal there. If this pain, if this headache is familiar, it can indeed be related to bruxism, to the amplification of muscular force. And the complementary differential exams that I'm going to teach you here, closure and support. Closure of the differential diagnosis. Okay, guys? It's not about the procedure. No. There's no way to get a differential diagnosis wrong because it's a diagnosis. So it's not a procedure where you need to deliver spine, eye posture. It's a differential diagnosis. These are the complementary differential exams. I published this in 2019. I've been doing this for 5 years. All my patients undergo the diagnostic splint exam and polysomnography. These are 2 exams that increase your revenue with a lot of integrity. You paint this splint red, a thin layer of red paint, a thin splint with a suitable paint that doesn't come off with water, only with pressure or grinding. There has to be friction, a little bit of friction. You can see if the patient is doing eccentric bruxism, eccentric movement, or both. So the polysomnography is for you to rule out apnea. There are lots of patients with apnea. According to the WHO, only 10% of patients with apnea are diagnosed. So maybe your husband has apnea and he snores and you don't know if it's apnea or not. Maybe he does, your wife, your husband, and you've never done an exam. So how do you do a root canal, for example, without an X-ray? You don't. How do you do an implant without an X-ray or a CT scan? Often you don't. How do you place a restoration without doing a diagnostic wax-up? Without knowing what the patient does during the night? So be careful. Be careful with the lack of knowledge about bruxism. This is a crucial moment in our life as dentists. So let's go. Let's move forward. We are now going to deliver the differential diagnosis to our patient. And look, there is mild, moderate, and advanced bruxism. There are 3 categories of bruxism intensity. And our treatment for bruxism will be different for each of these categories. And the treatment includes supplementation. It includes adjustments to habits and sleep routine. The treatment includes occlusal adjustment, as I mentioned, to reduce occlusal problems. The treatment also includes an appropriate mouth guard, depending on whether the patient has sleep apnea or not, whether it's a day or night guard, whether it's 1 or 2 guards, and whether it's for the upper or lower arch. There are several types of mouth guards. You can't just guess, folks. I'll break down this treatment during Advanced Dentistry Week. If you haven't registered yet, when this class is over, go to the link in my bio, sign up, enter your best email, put your phone number, don't leave the WhatsApp group, or if you're here on YouTube, check the comments. You'll learn this during Advanced Dentistry Week for free. Now, this exam, this very exam, increases your revenue even if you don't charge for consultations. Why? You don't charge for the consultation, but you do charge for the exam. If you work with health insurance, you saw the patient through the insurance, but you charged for the exam. So pay attention. This is a template I give to my students. My students, they already do the exams, all of them. And look how interesting this patient's complaint was: a fracture of 2 teeth, sometimes 2 heads, the patient Juliana. From dentist Luciana Porto Guimarães, from Belo Horizonte, Minas Gerais. And she charged then for the diagnostic splint exam, 550 reais. Luciana used to see a lot of health insurance patients, and this is a patient who came from health insurance. So she takes Ansitec, Valigia, look at that, a bunch of anxiety medications. And what does she have? Bruxism, because anxiety medication increases muscle dysregulation. And this muscle dysregulation often causes bruxism. Patient result of the diagnosis. Notice that the patient still has canine tips. Notice that her occlusal surfaces are still intact. Take a look at that. So when you look at this mouth, you wouldn't even think she has bruxism, right? But she does. And how does she? Remember the 360 medical record I told you about, which is part of the differential diagnosis? That's right. The 360 medical record leads you to perform the diagnostic splint exam, which increased Luciana's revenue by 550 Rs. Have you ever thought about your very first appointment already bringing in 550 Rs on the first day you see the patient just with one exam? Well, that's possible. It's not just for me. It's for Lou, who's over there in BH in Minas Gerais. It's for you too. I have a student from Boninal, a town with 14,000 inhabitants. I have a student from Boninal who transformed his clinic with these exams I'm teaching you here. I'm teaching you for free how to do this and to understand the patient's profile. Today, the only people who close their eyes are those who don't want to grow. My question for you is, do you want to grow? If you tell me I don't want to grow, I don't want to earn more, then this really isn't for you. But if you want to grow, want to stand out, want to be a reference, want to earn more, come with me. So 360 medical records, let's continue. I won't have time to talk about everything, but I want to show you this here. This is a question. This is a questionnaire validated in the literature. It's called the Epworth test. A score above 9 already indicates abnormal sleepiness. This patient had 14, so she most likely has sleep apnea. She didn't know that. She had never taken this test before. Who took the test? Luciana Porto Guimarães from BH, my student. Okay, everything is noted down here. We discussed this in the mentoring sessions. I go over each of the what she has, each of the medications she takes, how often she drinks coffee. We discuss all of this, but now is not the time. Now let's look at the diagnostic splint exam. Advanced mixed bruxism. There's centric, there's accentuated movement. There's centric, of course, she has cusp tips. I still have a bit of red, see, on day 3. I have a bit of red, but look how it was on day 0. It was all red. These were all the movements she made during the night. Advanced bruxism. It needs to change. The patient looks at this exam and says, wow, I did this during the night with this thin little splint. Imagine what I do to my own teeth. So it brings awareness to the patient. The patient pays for the exam. And then as a complementary differential exam, polysomnography. You might not be seeing this in reality today or know how to put this into practice, but I'm going to teach you during Advanced Dentistry Week, which is totally possible for any field, any specialty. I know that many times you're not even seeing your child. He leaves school. You're not even seeing how he sleeps. He leaves school and you only get home late. But many children also have bruxism. So be careful. This will help you in 2 ways. First, to become a reference. Second, to bring 3 things. To be a reference in your region. Second, to bring quality of life to your patient and to yourself, and to increase your revenue. So do what I'm telling you. Join Advanced Dentistry Week and understand what I'm showing you now. The polysomnography showed that she has apnea. What is apnea? Airway obstruction. During sleep, oxygen levels drop. Do you remember when we were dealing with COVID and people's oxygen saturation would drop to around 94 and everyone would panic? Exactly. At night, there are people who drop to 60, 70. She dropped to 82 during the night without knowing. So this test will help you connect with the patient in such a way because she had apnea and didn't even know it. What did Luciana become? She became a safe haven for her. You're going to explain the risks of apnea. Her sleep efficiency is terrible. A sleep efficiency of 75% is terrible. Why is it terrible? Because the patient should have at least 90% sleep efficiency. So, for example, she might not be able to lose weight. Her hormones are low. She could be entering menopause. Look at how many things. You're starting to build a support network. And another detail, this is a patient who cannot use a flat splint. Why not? The jaw moves further back, which increases the apnea. Maybe you're giving out a flat splint, a stabilizing splint, a Michigan splint, whatever you like to call it. Yeah, muscle relaxant isn't used anymore, but there are still people who call it a muscle relaxant. Why isn't it called a muscle relaxant and why isn't it used anymore? Because it doesn't relax the muscles, right? That's proven. The splint provides protection. So let's continue. Whatever you want to call it, you can't give it to a patient with sleep apnea because it will push the jaw further back. This is a patient who needs a specific splint for sleep apnea. So look at how much information I've given you here today to help you become a reference. So if you give a bruxism splint, if you give a patient a splint just because you think they have bruxism, because you see worn teeth and you don't do any of these exams, you're giving a splint blindly, you're giving them a crutch without knowing what their walking problem actually is. That's what you're doing. So be careful not to be that kind of dentist, okay? Let me show you another case. I'm already pretty far along in the live stream. This topic is really exciting. So let's move on to another patient from Pelotas, from Dr. Carmen Pedrera in Rio Grande do Sul. Paciente Eliana, 68 years old. Chief complaint: toothache in the canine, number 23, and radiating pain. Oops! Now the diagnosis gets more difficult. Pain at the bottom of the sulcus in the area of tooth 25, in the area of tooth 34. Do you agree to let me do the exam? Yes, 600 reais. 600 reais for an exam that no health insurance covers, that only you will do. If you start doing it in your area, you'll be offering this exam. What do? I do it for all my patients. Do you know how long Carmen has been practicing? 40 years. If you're 30 or 40 years old, I want to say it's not too late. On the contrary, this exam doesn't strain your back, doesn't strain your eyes. Stop thinking you need to improve with super, ultra, mega, another 15 resin courses you've already taken. And you haven't applied even a tenth of each course in your practice, while this exam you can use with all your patients, and it doesn't depend on your eyes, your back, or your hands. It's excellent for thinking about retirement without leaving your practice but working much less. So, extremely exaggerated overbite occlusal problem. There's an occlusal issue involved here. Most likely, this patient also has apnea, a retruded jaw, facial muscle pain, and headaches amplified by bruxism, most likely. Let's check in the diagnostic splint exam, just as expected. She has centric bruxism. She clenches too much. Her jaw is a bit retruded. She has an exaggerated deep bite shadow. Look how the differential diagnosis is being formed. Look at the movement she makes during sleep. As a result, centric and eccentric bruxism, but more centric. More on the left side, where she sleeps more on her right side. And where did she have pain? In the region near tooth 23 and 34. Look how interesting. She has pain on the left side. Why does she have pain on the left side? She also moves more on the left side. Look how interesting. She makes more movements on the left side. So that's where she does the bruxism. But where did we see that? On the diagnostic plate. Look how interesting. Isn't that interesting? Guys, I think that's beautiful. Very well. I want to tell you that after everything I've shown you in today's class, if you've been practicing for more than 30 or 40 years, don't be afraid. The time is now. Come join us for the Advanced Apology Week. Tomorrow we have another live session, and it will be a pleasure to have you here again. I want you to check out Juliana so you can see how it works in the hands of all dentists, not just mine. That's what it's about. It's about methodology.
Before Dr. Andrea's methodology, when a patient came into my office, I would do a basic anamnesis, and from there I would focus on the symptom, what was needed, and their main complaint. What I used to do was rehabilitate the patient, get them into an ideal occlusion based on a centric relation that I determined, and from there I would proceed with the rehabilitation. I didn't look at how their bruxism was. I didn't pay attention to the other aspects, and I found this to be a real turning point. From now on, I'm sure my rehabilitations will be much better, thanks to a much more accurate diagnosis. And because of that, I was able to give my patient much better health. Many times, we feel undervalued when we have to work with health insurance plans, or when many patients don't want us to charge for the consultation. But I see that when we have something that sets us apart from other professionals, when we have different knowledge, like with bruxism, this makes the patient value us much more, and we can see a light at the end of the tunnel. Because having something that sets us apart, especially when it comes to bruxism, which has increased a lot now with COVID, changes our schedule, changes the way we look at patients, and our expectations about the profession also become much better. With this knowledge, we're able to add value to our work and bring many more patients into the office.
So that's it. It's about being a reference, standing out, and increasing your revenue. With integrity, delivering what the patient needs. I'm waiting for you at Advanced Dentistry Week. Click the link in my bio or in the comments here on YouTube. Enter your best email and your WhatsApp, and don't leave the group, because there I'll teach you how to become a reference dentist in your region, increasing your revenue with a lot of integrity, even if today you don't charge for consultations or work with health insurance. It's for you too, no matter how long you've been graduated, differential diagnosis, treatment, and control of bruxism. Kisses. I'll see you tomorrow in class, and I'll see you on Monday at Advanced Dentistry Week.